Suresh and other people will be panelists. So Vidya, I would request you to talk to your husband, who is a expert in ICU, who can give a talk on treatment guidelines for septic shock on 4th. Today's speaker, all of you know, Suresh Kumar, the fellowship in HIV/AIDS, NAB assessor, co-founder, Best of IDs, a senior consultant, infectious disease, Apollo, Chennai. Dr. Vidya Sundaresan is not new to us. We had been coming to our webinars quite often. Very interesting personality, a professor and chief program director, fellowship, infectious disease, SIU School of Medicine, medical advisor, local health department, and is a governor of ACP, Illinois South. Dr. Sivakumar, whom you remember, he was there with us meetings earlier, is a MBBS DA, IDCCM, PDIC, and FICCM, is Head Institute of Critical Care Medicine, Royal Care Hospital, Coimbatore. He is also an accredited teacher for IDCCM and IFCCM since 2015. Secretary for Indian Society of Critical Care Medicine, Coimbatore chapter. Kandaswamy Subramaniam, whom you had interacted last week, is a professor of critical care medicine, head of surgical intensive care unit, Christian Medical College, Vellore. He is well known for his expertise in anesthesia and intensive care in India, United Kingdom, and Australia. Healthcare services, quality, and safety are his prime focus. He is dedicated to delivering affordable critical care to all economical and geographical sections of the society by practicing disruptive innovations. He has more than 30 scientific publications to his credit. Our future programs, we are planning to have 4 programs on every month on headache, high blood pressure, new drug, and diabetes management, about which we will talk to you later. And all of you would have received our MediBeats newsletter. And those of you who have not received MediBeats newsletter, you can visit medibeats.org website, and you can download all the 5 issues. Today we have released the 6th issue also. With this, I now request Dr. Suresh Kumar to present his slides. I will stop sharing. Suresh, you can go ahead and share your slides. Yes, Suresh?
Yes, sir. Yeah. So thanks for the kind words of introductions, and thanks for the wonderful opportunity. Today, since multiple speakers will be there, I'm going to cut short my talk a little early so that others can have better presentations and better discussions at the end. That's my aim today. I hope my slides are visible or I'm audible. Am I audible now?
Yes.
Okay, sure. So my disclosures, we know this is a second Zoom meeting. The dress code will definitely change during the Zoom meetings prolonged. This is a second meeting. One more meeting is there in the next couple of days. And you can't get answers for all infection related, particularly sepsis related, and particularly antibiotic related questions. We try to simplify as much as possible today, but you can't expect everything today. That's more important. As my style, usually I begin with a case here, 42-year-old male, no comorbids. He admitted with burns for 40% burns. Day 5 of hospitalization, he started developing fever and new onset hypotension and hypoxia. His oxygen requirement went up. Initially, there was no oxygen requirement. Later, it went up to 4 to 5 liters. Then he required a little bit of NIV support. Majority of wounds, according to plastic surgeon, it's healing. It's not completely healed, it's healing. Central line was on place day 4 because his body almost 40% burnt out. There is no IV line access, so we started at central line. And urine routine analysis showed 2 to 3 pulses. X-ray chest was normal. Urine cultures, no growth. Serum procalcitonin sent on day 4 and day 5 of the illness, it showed above cutoff of normal. Serum procalcitonin 4, the cutoff is 0.5, you can keep it right now. I'm going to ask the participants, please go ahead. What antibiotic would you like to start? Since this is a GNP sepsis talk, so I don't want to put any gram-positive cover here. Just what is your preferred gram-negative antibiotic when you think the patient's admitted with sepsis in ICU? Ceftriaxone, 3rd generation cephalosporin, or cefotaxime. Then piperacillin tazobactam, that is FDA approved, or cefoperazone sulbactam, that is a workhorse antibiotic for most of the Indian ICU, or meropenem, imipenem, or you want to start colistin, or you want to start newer BL-BLA combinations, or you want to go with some combinations of antibiotic. Even though this is GNB talk, I want to give Miro and Manco. Please go ahead and put it in the chat column so that we can have a discussions at the end. So the objective is we need to learn the heart of war. Right now war is going on. So we need to know the heart of the war. Particularly we need to consider microbes as our enemy. So we need to know that drug is our heart. So we know the enemy, and if we know ourselves, particularly the drugs what I'm using for the enemy, you need not fear the results hundreds of battle. Unfortunately, the drug what we are using is not effective most of the time. At the same time, the enemy is also not known to us. Whether it's a sensitive one, whether it's a resistant one, I am not sure about it. That creates a problem. When the drug is also not effective, when the bug is also more resistance, most of the time we won't succeed. So we need to keep, we are not living in 1940s to 1960s or 1970, where most of the bacteria were sensitive to almost all the antibiotics, but we are living in 2010 onwards. 2010 onwards in India, most of the bacteria, particularly gram-negative bacteria, were resistant to our common antibiotic like cefotaxime, ceftriaxone, and even piperacillin tazobactam, and even nowadays carbapenem. So that is why we are discussing today the gram-negative sepsis. So if you see the Indian literature, the common bugs is not gram-positive. For example, if you see US, the top bugs in the ICU will be gram-positive most of the time, particularly MRSA or enterococci. But in Indian ICU, if you see what top bugs, usually Klebsiella and Acinetobacter, switching over the gears. Yeah, some ICUs can have Acinetobacter, some ICUs has got Klebsiella pneumoniae, and E. coli and Pseudomonas can have a supporting role to Klebsiella and Acinetobacter in most of the ICUs. So this is across Indian hospitals. This is a status I shown, and this is my ICU I published a couple of years back. It showed same thing. That point of time, Klebsiella is not a big bug, but nowadays Klebsiella playing a big role. E. coli, Pseudomonas, and Acinetobacter was a big concern, and Acinetobacter was a real concern because most of the time the carbapenems is not working for Acinetobacter. That's a real concern. Of late, we are seeing the same trend in Klebsiella pneumoniae. So this is a trend. This paper is almost now 10 years old paper now. So I'm going to tell how I'm approaching an antibiotic selections. Already a couple of chat box questions raised, and my co-chair answered that thing. Empirical antibiotic choice depends upon three things. What is a bug, or what is a syndrome the bug causes it? Second thing, what sort of host I am dealing with it, and what drug I am going to use it. If you know all the three, it's easy for you. That is why I told the battle is easy. When you know the bug, when the drug is very effective, we can kill the bug. So how to make a syndrome, or how to think about the bug? Usually in ICU, we put usually 7 syndromes. Particularly from head to toe, we can put the syndromes. First syndrome is meningitis and meningoencephalitis. Presence of fever, altered mental status, headache, seizures, on examination, neck stiffness, or some localizing signs. We put meningitis or meningoencephalitis. The second syndrome is pneumonia syndrome. Presence of fever, cough, shortness of breath, chest pain. The third syndrome is usually intra-abdominal sepsis. Presence of fever, abdominal pain, abdominal distensions, altered bowel habits. These are all the signs of intra-abdominal sepsis. The fourth one is UTI. Fever, dysuria, lower abdominal pain, hematuria, loin pain, we consider as intra-abdominal UTI. Then skin and soft tissue infections, fever, redness, swelling, tenderness. Apart from these things, ICU people use central line and arterial line. When central line or arterial line is placed, new onset hypotensions, redness at the site of the insertions, we consider central line related bloodstream infections. Then finally, even with these syndromes, sometimes we can't able to localize it. That's called fever without source, or new onset fever in ICU. That sometimes is a bit challenging and a bit difficult also. So these are all the 7 syndromes we usually encounter. And usually the bugs say the gram-negative or gram-positive. And Indian ICU is mostly gram-negative, plus or minus anaerobe may be required. Gram-positive is still possible, but the numbers is a bit less compared to the Western world. And most challenging part is the resistance pattern. For example, the E. coli Klebsiella resistance in Indian ICUs is mostly, particularly the Klebsiella Acinetobacter, the resistance varies anywhere between 50% to 90%. Some of the ICUs is 100%. Acinetobacter resistant to carbapenem is 100%. Klebsiella, it varies. In southern part of India, it varies between 30%. Compared to northern part of India, it goes up to 70%. Depends upon how the antibiotic stewardship program in the hospital. And third thing is host. Usually what sort of host? Community acquired or hospital acquired? What is the risk factor for MDRO? So make a syndrome. Once you make a syndrome, think about the bug. If think about the bug, think about the resistance. That is very valid to start antibiotic. So this is common symptoms what I discussed now. Based upon the symptoms, based upon the signs, we can put the syndrome or we can put one or two syndromes. Because sometimes the patients can have altered mental status, tachypnea, patient has got shortness of breath, oxygen is dropping and BP is also dropping. Very difficult to localize whether it's meningitis, meningoencephalitis, or because of pneumonia. Rarely the patient has got urinary symptoms also, urosepsis related confusions. So it's very difficult, even though in theory it is easy to say syndrome, but the real challenge in the life is try to figure out where the sepsis is originating. In fact, we had discussed in the last meeting how to write the syndrome. Don't write sepsis alone. Please write sepsis, where it is coming from, and what sort of the host is getting sepsis. Keep in mind, that's why we need to understand the sepsis part. You need to understand all three sessions so that you can have some continuity and some better understanding of sepsis. Previously, we defined the host, whether the host come with sepsis or not, or developing sepsis in the hospital. Why? In the community, most of the time, the bacteria is not resistant. If you start in simple antibiotic, the success rate is very high. On the other hand, when a patient develops sepsis in the hospital, the chances of resistant bug is very high. That is why if you see the antibiotic stewardship of most of the hospitals, they put community acquired as class 1, and people are developing healthcare associated as class 2, and nosocomial or hospital acquired as class 3, where the patient is exposed. But right now, I'll come back. This approach is not a simple approach to me. For example, this is a paper from PLOS ONE. This is slightly older paper, but it shows even in 2013, according to the Western world, travel to Southeast Asia is a risk factor for resistant bugs. When a patient traveled Southeast Asia and started developing infections or sepsis in the country, they want to cover broad. Because they know Southeast Asia, most of the people has got gram-negative resistance, they want to start. But based upon this paper, can we extrapolate? So almost all the Indians carry the gram-negative resistance. According to this paper, Southeast Asians country, the resistance rate is very high in the community. If you travel to the part and stayed in the hospital a couple of days, the chances of resistance is very high. But we are living in India. Even though we know the resistance rate, for example, the New Delhi water contains carbapenem resistance, Enterobacteriaceae, and E. coli, and Klebsiella. The resistance bug is present on fecal material. That is why if you travel to Europe, I do not know about US, but in Europe, they travel our fecal examinations. If you try to hospitalize to check whether we are carrying carbapenem is producing Enterobacteriaceae or not. Because in Indian scenario, carbapenem resistance is very rampant in community setting. That is a problem. So, but we are Indians, how to choose an antibiotic when we are living in India, when we are exposed to carbapenem resistance. This is a big challenge for ID as well as ICU in India. If you see the global resistance pattern, the NDM1, where your carbapenems like meropenem, imipenem will not work. It's fully present across Indian country. Even though there is a slight difference between North India and Southern India, but still the carbapenem resistance is very high compared to other parts of world. Selected few countries has got the same problem, but most of the countries, the resistance pattern, what I am seeing is not present in the country. It's easy for them to practice ID in other part of world compared to India. So people always do whether the host is carrying. We can't say the person is coming from the community, is not carrying the resistant bug. The person admitted in the hospital is carrying the resistant bug. This scenario is not correct according to Indian scenario. So the better strategy is we need to screen what Europeans are screening the Southeast Asians. Similarly, we need to screen when a patient is admitted in ICU to check whether the person is carrying carbapenem is producing organisms in the fecal material or not, or in the rectal swab we need to do. Then only we can able to identify whether the patient is carrying resistant bug. If the person is carrying resistant bug, the person develops sepsis in the hospital, we need to start little broader, even more broader compared to what other people are starting. The better strategy is go for rapid identifications of a rectal swab or fecal material. We need to check whether we are carrying any resistance gram-negative in our bowel. That will indicate when you develop sepsis, it helps in starting antibiotic selections. People want to know, instead of going for a resistance mechanisms, Usually we told last time whether the patient is septic or not septic. When a person is really shocky, the score is, one of the scoring system has come up. This is called increment score. Based upon this increment score, I can say the person is very sick or not. Based upon the increment score, for example, the person presenting with septic shock or the Pitt's bacteremia score that is more than 4. I'll show in a minute what is Pitt's bacteremia score. Similarly, multiple comorbid conditions, Charlson's comorbid index of more than 2. The source of bloodstream infections other than urinary tract or biliary tract. It's very difficult to treat in other situations. For example, if the source of sepsis is lung, the source of sepsis is a bloodstream infection, this is big challenge. Then inappropriate therapy. So we need to put a score called increment score based upon the points. If the score crosses more than 7, the person is really septic or the person is really shocky. We need to start broad till we get the organisms known. So the two things we need to know: how sick is the patient and where is the sepsis. That's what I alluded last talk. How sick is the host and where is the infections. So this is called Pitt's bacteremia score and this is called the Charlson's comorbid index. We need to calculate the score. Based upon this score, we need to calculate the increment score. Unless we have resistance mechanism identifications by PCR techniques. If this technique is not available to you, rapid identifications, we need to go with some scoring system. This is a scoring system. For the scoring system, I need two tools. One is called Pitt bacteremia score. Other is called Charlson's comorbid index. Based upon the thing, I calculate the person's risk, how sick is the patient, so that I can start broader antibiotic. The patient is really sick, provided septic shock is high on the card. So this is what the recent guidelines, the recent guidelines of HICMET and IDSA says. We need to know, particularly the HICMET guidelines come up with guidelines saying that whether it's a low risk infections or high risk infections based upon the score what I just alluded a couple of slides back. Once you made the diagnosis of sepsis and septic shock and the increment score is very high, we need to take appropriate cultures, and start antibiotic based upon how sick is the host. This is a mantra for you people. Previous approach, send blood cultures, wait for the blood cultures report. But we are living in 2022, so all are going molecular. We need to identify the organisms. Previously, the culture should grow, then only I can identify. But people are using a lot of molecular methods. Once the culture bottle flags off, we need to identify which bacteria is present in the blood. Within 1 hour, we need to know this is a bacteria, this is a resistance mechanisms. So we need to go with better identification mechanisms to get the bugs. And people are getting even more better with SeptiFast. Even when the patient comes to the emergency, take the blood. When you stabilize the patients in ICU, by the time the culture report is back, the molecular panel is back, we know what bug we are getting in and what is the resistance mechanisms we need to target it. These things is not available in the secondary as well as tertiary, the secondary and primary level. For that only I told, go with your score based upon your increment score. How sick is the host? We need to start and send a standard cultures, look for the bacteria, treat accordingly. But people living in a cities like and practicing in a tertiary care hospitals, we need to go a little faster and find the bacteria. According to the bacteria, I need to react. So the last part is agents, antimicrobial agents. What are all the antimicrobial agents? Even though we are using only selected 10 to 15 or 15 type of antibiotics, but we need to know what bacteria, what antibiotic. That is major thing. But unfortunately, the resistance mechanisms keep rising. Initially, penicillin is not working. Then third generation cephalosporin stop working in country like India. Then people start working carbapenems. Carbapenem resistance happen. Off late colistin resistance also emerging now. Then people introduce new antibiotic, ceftazidime avibactam, that is also resistant. So the spectrum is keep shrinking. Previously, the bacteria will work for most of the bugs. Now the spectrum is shrinking. Only 1 or 2 bacteria only most of the antibiotic is covering. So this is in simple. For example, if you are using BLBLI like piperacillin tazobactam, it has got decent gram-negative cover. It covers E. coli, Klebsiella, Enterobacteriaceae. It covers Pseudomonas. It covers Acinetobacter, provided the bug is sensitive. But it won't cover MRSA. It won't cover resistant bugs. The BLBLI like piptazo and cephalosporin sulbactam is equal to your meropenem. Only thing, the meropenem has got a lot of pharmacokinetics advantage. Penetration is much better and the efficacy is much better. A couple of trials has proved it is very efficacy compared to BLBLI. So common problem in ICU is gram-negative resistance because patients admitted in a small hospital received cefotaxime, received piperacillin tazobactam, and referred to your hospital. Still, the patient is in septic shock. That point of time, if you do the culture, carbapenems are resistant. So if the carbapenem resistant pseudomonas comes, the options are very limited for me. I need to use old outdated drug like colistin and aminoglycosides or phosphomycin may work. Aztreonum, if it is working, that's well and good, but most of the time aztreonum is not working. So the other drug what Western people are using is ceftolozane tazobactam. It's not available in India at this point of time. For Enterobacteriaceae, the spectrum is expanding. Previously, it uses colistin and polymyxin B. Of late, people are using ceftazidime avibactam most of the time, plus or minus aztreonum to take care of NDM1 bacteria. Acinetobacter, if carbapenem resistance is gone, the options are very limited because ceftazidime is most of the time resistant. Avibactam has got no action against Acinetobacter. So we need to rely on sulbactam, or we need to rely on minocycline, or we need to rely on whatever drugs is working on. So this is a problem with Acinetobacter. These are all the three common bacteria we encounter in our day-to-day practice. People thought colistin and polymyxin B will solve the problem, but of late colistin and polymyxin B is also not working. For example, this is our publications 5 years back. Colistin resistant bacteria, we got it. Why? From 2009, 2010, we start using a lot of colistin. Colistin resistant bacteria emerged despite best of ICU, best of ID care. Still, the patient is not going home. If you see the last column, out of 16 patients, most of the patients were expired or lost to follow-up. So almost 13 to 12 patients died when colistin resistance happened to the patients. So people thought of colistin is gone. In fact, the Western world, they've given up colistin and polymyxin B. Now they're using ceftazidime avibactam and other combinations, what I mentioned below. But in India, only ceftazidime avibactam plus aztreonum is available to me. So if you see the ceftazidime avibactam plus aztreonum, it will take care for most of the bacteria. But the problem, the brain penetrations of ceftazidime avibactam is not great. That's a real challenge for me. Other things is not available. Soon in 2022, these drugs is going to be available in India. We need to prepare for these drugs, how to position and how to use this molecule. That is the way forward in 2022. So the common mechanism is ESBL. For ESBL, either you can use BLBLI like piptazo or cefoperazone sulbactam, or you want to use meropenem. This is a big debate is going on, whether I need to use meropenem for my ESBL producing organisms. ESBL means third generation cephalosporins will not work. So for third generation cephalosporins will not work, what is a drug of choice? Either piptazo versus meropenem. Couple of trials looked into the data, but this is a famous trial called Merino trial. It showed carbapenem is superior. But unfortunately, if we start using carbapenem resistance is emerging. So what we need to do, we need to streamline. Not everybody need carbapenem. If you read the IDSA guidelines, they want to use carbapenem for all third generation cephalosporin resistant bacteria. But if you read the ICMET guidelines, we can. Of late, last week, one of the publications came, if the source of infections is urinary tract, that is one of the questions one of the chairperson raised, whether what is the best drug. That depends upon the resistance, that depends upon how sick is the host. So depends upon the thing and depends upon what antibiotic available to me I can choose. Empirical therapy, we need to start broad, provided the patient is septic shock. If the patient is stable, at least we can try your cefoperazone sulbactam or piperacillin tazobactam. People want to know which is best drug for carbapenemase producing organisms. Colistin versus ceftazidime avibactam. Yes, this is always a debate. Colistin is slightly cheaper, but nephrotoxicity. Ceftazidime avibactam is costly, but unfortunately, the resistance to ceftazidime avibactam is emerging, and it is not going to work for your NDM1. We need to add aztreonum. This is a big challenge. So in short, where is the source of infection? Respiratory tract means we can use either polymyxin or Cas-AV plus aztreonum. Intra-abdominal infection, tigecycline is a better choice. Urinary tract infections, carbapenemase producer, colistin is better choice. If colistin is not possible because of nephrotoxicity, consider Cas-AV plus aztreonum plus or minus phosphomycin. Catheter-related infections, either colistin or polymyxin B. If not, if the creatinine is very high, think about Cas-AV plus aztreonum. Meningitis, always consider polymyxin because Cas-AV has got poor penetration to the brain. But most important thing, the durations. The durations for sepsis is hardly 7 to 10 days. Don't overshoot more than 10 days for most of the sepsis. Most of the sepsis, keep in mind, 7 to 10 days is a timeline. So don't confuse. My other speakers will sort more things because I need to rush. Even then, I overshooted my time. Carbapenem sparing regimens are still possible for ESBL. Don't think ESBL means I need to use carbapenem. We can still use cephalosporin sulbactam. We can use other positive sensitive agents. Therapy for carbapenem producing organisms is a bit challenging. Individual patients only. There is no clear-cut guidelines I can use. Go with individual therapy. What is available? How sick is the host? That's the two things I'm deciding it. Expertise is definitely needed to treat carbapenem producing organisms because we are treating for the last 10 to 12 years the resistance mechanisms. Definitely HID people like ICU people like my co-chairpersons, they can use it along with microbiologist support because we need to get the bug out early. So don't think you can't retain everything. Only 80% of the things is going out of your mind. Keep frequently attending the sessions. The next session also available next couple of days. So if you want to interested more ID, please feel free to contact us. We can provide more support. Thanks for the wonderful opportunity. I stop at this point of time and we can discuss at the end.
Thank you, Dr. Suresh, for that nice and short presentation. Now I'll request Vidya, please take over and give your experience about gram-negative septicemia and then approach, simplified approach, for the practitioners. Go ahead, Vidya.
I'll thank you. Actually, thank you for the invitation, and I'm really happy to be on this conversational webinar with the Q&A. I'll give you a little bit of a perspective of how things are here in the United States. It's pretty much the same, like how Dr. Suresh Kumar summarized. Gram-negative sepsis is an important part of admissions to the hospitals, to the ICUs. Gram-positive as well as gram-negatives. In fact, now that is the bigger elephant in the room with gram-negatives. A lot of the infections are caused by E. coli, but 20% of the gram-negative infections are E. coli. Klebsiella is next on the list. And then we have Acinetobacter, Stenotrophomonas. These are some of the other organisms where you can see hospital outbreaks as well. So you have to be mindful of those. You have rare gram-negatives causing these alkalogenous, etc., coming from wounds, which can cause rare gram-negative infections. Pseudomonas is a big nosocomial organism. Enterobacter is a big nosocomial organism. So we tend to see all that as well. Although earlier predominantly we would see gram-positives, gram-negatives are taking over in the ICU as the predominant infections now. Gram-negative resistance is a big problem worldwide. We have to use our antibiotics prudently. Antibiotic stewardship is key. It started out with the widespread use of quinolones, levofloxacin. We used to call it vitamin L. It used to be given to everyone. That has increased the rates of C. diff and gram-negative resistance, starting out with that. So quinolones gone. And then remember, bugs are always smarter than us. So with widespread use of just beta-lactams and beta-lactam inhibitor combination, we started losing that whole group. Then cephalosporins. Bugs got smarter. Cephalosporinases is the enzyme that they produce, and cephalosporins as a group got knocked off too. Higher up in the hierarchy is carbapenems, and then we see carbapenemases, which is the enzyme that knocks off carbapenems as well. So we have to really be prudent about the antibiotics that we use in the hospital. I'll stop there, and then we can take the focused discussions and questions.
Shivakumar, are you there? Shivakumar? Yeah, please go ahead.
Good evening, sir, and thanks for the opportunity.
Okay.
I think I would like to toe the same line as my earlier speakers, and just to briefly discuss about the management of gram-negative sepsis. I think I think all my co-panelists will agree that probably we are seeing more and more gram-negative sepsis. Some are community acquired. I think in India with large diabetic population, I think we are seeing a lot of patients with from the community coming with severe urosepsis and multi-organ failure. I think that numbers are increasing day by day. Maybe as far as the hospital-acquired gram-negative infections are concerned, it's predominantly your ventilator-associated pneumonia or bloodstream infection. When I say bloodstream infection, it is not only the central line related. Of late, what we are seeing is there are a lot of bloodstream infections related to peripheral lines. I think that has to be probably kept in mind. There are a lot of bloodstream infections related to your peripheral lines, and maybe the genitourinary also has to be taken into consideration. These are some of the gram-negative which are hospital-acquired. Predominantly, it is ventilator-associated pneumonia followed by bloodstream infections and urinary tract infections. So these are the spectrum of infections probably which we come across. As far as management goes, as far as the management goes, I think though we talk a lot about antibiotics, I think all the three things like the diagnosis, antimicrobials, and the source control has to go hand in hand. Probably, if not simultaneously, if not sequentially, it should be done simultaneously. I think probably in the last webinar you discussed about the diagnosis. So I would like to reinforce the fact, though everyone is very fond of or very good at starting an antimicrobial, the equally important is to make a diagnosis, and that aspect the cultures are very important. And all the attendees, I think, should, whenever you suspect an infection, probably depending on the source, you should send appropriate blood cultures. And when the patient is more sicker, probably you should send a blood culture as well. So when I say blood culture, I think you should send adequate amount of blood culture. Probably we send just 10 ml or 15 ml, I think may not be adequate. So you should send from 2 different sites, and at least 20 ml each from 2 sites is important to get better yield. So the diagnosis is equally important. So there are a lot of rapid tests. I think Dr. Suresh also mentioned during this lecture. So it is not widely available in most of the centers, but at least you could send a blood culture, and if you are suspecting various sites like a urinary site or a pneumonia, probably you should send other cultures as well. This is with regard to diagnosis. When it comes to management, I think Dr. Suresh has very well explained in detail about the lecture. I think certain things should go through your mind, and probably before you just prescribe an antimicrobial. So I think what I would do or what I would do in ICU is probably first thing I would think about it is whether it is an hospital-acquired or a community-acquired. The next thing would be, what is the host? I think what is his age, what are his comorbidities, what is the severity of illness, whether he is hospitalized in the past, whether he has received antibiotic in the recent past. This thing should run past your mind before you choose an antibiotic. Next thing would be, what is the site you're thinking about and what is the drug you want to choose, whether this drug would adequately concentrate in that site. Suppose you're treating meningitis, you're treating a cholecystitis. So your drug should be able to concentrate in the CSF and the bile. Then probably what could be the likely organism you're going to target and what is the sensitivity of that organism in your hospital or in your ICU. So all these things should run past your mind before you choose an antibiotic. And as Suresh rightly mentioned, I think we are in an era of multi-drug resistance, and most important is once you start an antibiotic empirically, 48 hours down the line, you get a culture report, you make a correlation clinically and microbiologically, decide whether to continue these antibiotics or to de-escalate, or if you think it is a non-infectious cause you're dealing with, whether to stop the antibiotic. This is very, very important. See, very easy thing is to start an antibiotic. So once you get the culture report, make a clinical correlation, decide whether to continue antibiotic or to stop antibiotic or to de-escalate the antibiotic. Sometimes at least you started a gram-positive and a gram-negative empirically, at least you should stop the other agent, whichever is not necessary. This is very, very important. Or when you're suspecting an MDR organism, you started a combination therapy, you get your culture report, probably you should think about de-escalating. The next, Suresh did mention about duration of therapy as well. One important aspect of antimicrobial stewardship is to restrict the duration of therapy. I think we are all good at giving long therapies. I think now even for WAP, I think 8 to 10 days of therapies are good enough. So there are very good guidelines available, and probably we should de-escalate, and we should try to adopt shorter therapies as much as possible based on the etiology. I think that's all from my answer.
Yeah, Shubha, thank you. Vidya, are you there? Dr. Vidya?
Yes, doctor. I'm
Vidya,
here.
you are talking about something like rule of three. What is the rule of three?
Yeah. Sorry, I don't know if it's just me. Are you able to hear me?
Yeah, I can hear you.
There's some feedback. Yeah. So doctor, for de-escalation.
No problem. But if we have to go to
Yeah.
the center, we can pay $1,500 for
Dr. Morgan, please switch on.
Yeah. Sorry. Is it okay now?
Yeah, this is better. Thank you.
Yes.
Yeah, so doctor, I think this has been mentioned by both speakers earlier. It's very easy to start out with broad spectrum antibiotics, which is the right thing to do. When a patient with suspected sepsis is in the hospital, you want to start with broad spectrum antibiotics because you really don't know what's going on. So you want to start broad. When we say broad spectrum, gram-positive, gram-negative coverage, anaerobic coverage, and depending on the host, sometimes presumptively even antifungal coverage. If this is a patient who's getting chemotherapy, they're neutropenic, they have a high risk for aspergillosis. So presumptively, depending on the host, you can even start antifungal treatments. For de-escalation, typically, if you look at the stewardship literature from IDSA, they talk about a rule of three. So you assess cultures, you collect cultures. So cultures should be taken before start of antibiotics as much as possible. You want to start antibiotics within the first hour, depending on the severity of the patient's illness, a septic shock. Definitely, you want to get that antibiotic started within the first hour. Because every hour delay in antibiotic increases mortality as well. So you get the antibiotic started, get the cultures first, get the antibiotic started, assess at day 3. So most of the cultures should have some report back by day 3. With the MALDI-TOF and rapid tests that we have, PCR, these are able to get you the results even faster. So you know if the patient is colonized with MRSA. I heard about the CRE screening, which is excellent. So if you already know that there's colonization in this patient, then de-escalation, if the patient's not colonized, you can de-escalate faster. A lot of our pharmacists are using this MRSA screen to even stop antibiotics for MRSA if the patient is negative and they're not colonized. I don't completely agree with that because sometimes the cultures are gold standard. So day 3, you should have most of the preliminary data available. By day 7, you should have all of your cultures finalized. So your antibiotics should get further streamlined. So day 0, you're starting broad, you're assessing, you're getting your cultures. Day 3, you're looking at your cultures and looking at that preliminary data and making changes to your antibiotics. By day 7, you have a lot of those cultures finalized. So you should streamline your antibiotic even further. And by day 10, you don't have an answer, all your cultures are negative. At least you should have something in the way of diagnosis or identify the organ system, identify where this is coming from, and then have a plan for your antibiotic regimen. So that is in an informal way referred to as the rule of 3. So assess at day 0, day 3, day 7, day 10. By day 10, you should have a plan for your antibiotics and stop what's unnecessary.
Thank you, Dr. Vidya, because we had been discussing about rule of 3 earlier, so I thought you will bring that point. That'll be very easy to understand. Subramaniam, you tell us, in your experience, what are the patients category more critical to manage with gram-negative sepsis? Dr. Amit Agarwal is asking that question. Subramani?
Yes, sir. So the effect of the sepsis or the septicemia depends upon the virulence of the organism and the host. And if the host is compromised, like, whether the patient has on immunosuppression or
Subramani, can you talk a little louder? Can you come near the microphone and speak?
Just 1 second, sir. I changed my mic to a different one.
I think your microphone is voice resistant.
Is it better now?
Yeah, it's better.
Okay. So it depends upon the host and also the virulence of the organism. So if I have a patient who is having some chronic illness like diabetes or renal failure on dialysis, or patient has HIV, or patient is on immunosuppression or any steroid, these hosts will actually be more compromised than somebody who is otherwise well. So they may become more sick, end up with more organ failures, and the outcome is going to be poor in this group of patients.
How to manage gram-negative sepsis in immunocompromised patients, Dr. Sarkar?
Yeah, so the choice of antibiotic will depend upon the patient and depend upon your hospital antibiogram. So, like if your hospital has a lot of resistant gram-negative organisms, then your treatment should be directed against those organisms. So my hospital is a tertiary care center, and we get patients from all over the country, and most of them have resistant organisms. We may start with meropenem to begin with straight away, and add colistin if they are not getting better clinically, and depend on more of the microbiology, who will give us a bit more information. They do checkerboard analysis and things, and give us the choice of antibiotics. If they're in shock, we will rapidly escalate.
Dr. Vidya, would you like to add whatever Subramani said about the immunocompromised patient?
Yeah, Doctor, I was just thinking immunocompromising conditions. That's like a huge umbrella. So many different conditions there. For most part, I think Dr. Suresh Kumar put this in the chat as well. For neutropenic fevers, we really consider Pseudomonas as one of the organisms high on the list. So you definitely want a gram-negative coverage with pseudomonal coverage. So remember, not all gram-negative antibiotics have pseudomonal coverage. So a third-generation cephalosporin, ceftazidime, and then fourth-generation cefepime. That is something that we use commonly. Piperacillin tazobactam, that's the beta-lactamase inhibitor combination, that's also used for presumptive gram-negative coverage in these patients. And based on the risk factors, again, like it was mentioned earlier, Dr. Shiv Kumar mentioned this, risk factors. You want to take into account risk factors. If the patient has been in the hospital multiple times, if they are living in an extended care facility. So here we have patients coming from nursing homes, etc. So they tend to have a lot more resistant infections. If they have diabetes, other host factors, all those risk factors which can contribute to the presence of a multi-drug resistant infection, then you can presumptively go with carbapenem. We really try to steer away from carbapenems. We do not want to use carbapenems upfront. And you'll see that as the practices in the hospitals change, you are able to use simpler antibiotics for these patients as well. So back to the immunocompromising conditions, we see a lot of HIV patients in the hospitals too. We do not typically put them, if they are with an opportunistic infection in the ICU, if they're neutropenic, that's when we really go ahead and add broad spectrum antibiotic coverage. But otherwise, if they're based on their CD4, we decide what antibiotics to really use on them. So again, it depends on what we are talking about when we say immunosuppression. For most part, it's neutropenic patients. You definitely want to have at least a pseudomonal coverage on board. And if there is a suspicion for a line-related infection, if they have ports, etc., that's when you want to add vancomycin or some broad gram-positive coverage as well. And like I was mentioning earlier, if there is a suspicion for aspergillus, you got a chest x-ray, you're wondering if this patient, again, if they've been on antibiotics for a long time, they are at a risk for candida infections and other fungal infections too. So presumptively, a lot of time we end up adding posaconazole or voriconazole there is a mortality benefit for these azoles as compared to fluconazole, again, based on the type of immunosuppression. Bone marrow transplant patients are by far the most immunosuppressed. Lesser than that is solid organ transplants, then below that is patients with chemotherapy. So depending on their level of immunosuppression, you can decide on the antibiotic coverage.
Thank you, Vidya, for covering the whole spectrum of immunocompromised and then relative treatment. Thank you very much. Kanswami Subramaniam, please tell me, normally when we refer any case to any big institution, they straight away start meropenem or piptas. It looks like, sepsis is a meropenem deficient disease. So immediately they start meropenem. So what is your take on this? In a setup like a Christian Medical College, Vellore, do you use that like that every time, or how do you approach?
So the incidence of ESBL is very high, sometimes about 85-90% ESBL. We may start with the BL-BLI to begin with, and depending upon how the patient progresses, we may escalate to a carbapenem. And even carbapenem resistance is becoming very heavy. What we see is many of our patients, unlike what Dr. Vidya says, many of our patients have Klebsiella and multi-drug resistant Klebsiella. That's the biggest killer in our, and E. coli are the biggest killers in our ICU. Pseudomonas we do see here and there, but not that very often. I don't know what Dr. Suresh's and Dr. Shivakumar's experience are with Pseudomonas, but my problem is Klebsiella mainly. When you ask the question, will you straight away start on meropenem? Depends upon what antibiotic the patient was already exposed to. So the patient has been exposed to a BL-BLI before he comes to us and he's not responded. First thing is to see if we have sorted the source out properly. And the second thing is, a lot of drugs, we talk about antibiotics, we talk about dose. Current scenario, we need to think a bit more about pharmacodynamics and see how we give these antibiotics also. So like any cephalosporin or beta-lactam antibiotics, we give an extended infusion going up to 4 hours, and that increases the exposure of the bug to the antibiotic, and the cure rate is better. And similarly with aminoglycoside, we give once a day, so like if you use amikacin or gentamicin, use about 5 milligram per kilogram body weight dose. We do modify the way we administer antibiotics. And being a tertiary care teaching hospital, we have the pleasure of having, therapeutic drug monitoring. We monitor cholesterol levels, we monitor vancomycin, we monitor meropenem levels also. And we have a good clinical pharmacologist who helps us with all these multi-drug resistant organisms. So this is how I would take when you refer a patient to me.
Thank you, Subramaniam. Now you are saying about monitoring the drugs. What's the benefit by monitoring the drug level? What do you achieve?
So we ensure that. So the microbiology will give you what you call the minimum inhibitory concentration. And based on that, we can adjust the dose to achieve a concentration, which will actually cause bactericidal effect. If you give a lower dose, especially in early sepsis, you have an excess of excretion, and in those cases, your tissue level can be low. And in those situations, we usually start with the bolus dose, and so to achieve a rapid high level in your to achieve a higher level rapidly in your bloodstream and the tissues, we start with the bolus and then use a TDM. After 3 half-lives, we use the TDM and adjust the dose accordingly. Patients also develop organ failure. The same way, we can avoid toxicities of these drugs when we use the therapeutic drug monitoring.
Thank you, Subramaniam. Vidya, there is one question by Dr. Yogesh. What is Zigris?
Yeah, so that's activated protein C. When I was training, when I was in residency, we would use that a lot in sepsis. So it's with the sepsis cascade, if you go back to the pathophysiology, there's a pro-inflammatory cascade followed by an anti-inflammatory cascade. So you want to kind of have something that's anti-inflammatory, that's definitely useful, and anti-thrombolytic, and also the fibrinogen that's breakdown of fibrinogen as well. So you're really avoiding any of the coagulation cascade that this whole cytokine response sets off. You want to try to offset that. So this is activated protein C, human activated protein C, that used to be given to patients with sepsis, gram-negative sepsis especially. But then we realized that this caused a lot of bleeding. Patients who were predisposed to having any strokes, you couldn't use them. So it was very. We realized the risks far outweighed the benefits of giving Zygris. So that has actually fallen out of favor. So we don't use Zygris anymore here clinically.
Okay, Zygris is not
also.
Yeah,
Is it available, Zygris?
Subramani, little louder, please.
No, I don't think Zygris is available anymore.
Yeah. Okay. No, the point is Zygris is a protein, activated protein, correct?
Your coagulation cascade. So you're giving that human activated protein C. You're artificially giving that. So in a way that you are trying to avoid DIC, but it predisposes to the risk of bleeding. Okay. So this was just to interrupt the pathology for DIC, which you see in sepsis.
Okay, Suresh, I'll come to you. In every case, do you use bolus and then de-escalate, and how do you approach? But simply, don't talk too high-tech terms. For practitioners, do you use bolus, what Subramani was saying, and then Vidya was saying de-escalate? How do you approach? In a simple term.
The bolus is for only selected antibiotics, not or for all the antibiotics. For example, we divide the most of the antibiotics based upon the pharmacokinetics, whether we need to reach a level just above the MIC threshold for how much time. That's called, they need to maintain the levels for one dose to other dose almost 40 to 60% of the time. And second type of antibiotic, we need to hit very high concentrations so that we can kill the bug and it can drop immediately. So that's called concentration dependent antibiotics. So one is called time dependent, other is called the concentration dependent antibiotics. Usually for the concentrations dependent antibiotic, like colistin, we need to give the loading dose. We need to give the loading dose so that we can reach the sufficient concentrations within shorter span of time. On the other hand, some of the other antibiotic, for example, meropenem or other carbapenems or even BLBLI, what we need to do, we need to give a prolonged infusions. I got one slide because of the time, I removed it there. So this antibiotic need to be given as a prolonged infusions. If you give 4 to 6 hours, because some of the antibiotics, they can remain stable for 4 to 6 hours only. We do not know after 6 hours whether they can go remain stable in the outer environment. We do not know. So divide the antibiotics into pharmacokinetics, time dependent and concentration dependent. For concentration dependent antibiotic, loading dose might help. Time dependent antibiotic, infusion related. We need to give a slow infusions for prolonged time, 4 to 6 hours. And people are thinking about prolonging up to 24 hours infusions, provided the molecule is stable. So this is how we divide it.
Thank you, Suresh. Only I want to get that point out from you. Concentration and then time prolongation. So these two things one must know. Vidya, how to approach polymicrobial sepsis as commonly seen in diabetic foot syndrome? Palnichami Tangam is asking.
Yeah, that's a great question. But before that, I just want to add something to what Dr. Suresh Kumar said. Thank you. Very interesting concept that you brought up about time and concentration dependent drugs. Another important aspect is patient's weight. So a lot of these are weight based. And then if a patient is super obese, we have patients who are 300 pounds or higher here. And if we see patients like that, important to use ideal body weight or adjusted body weight. So we use a concept called adjusted body weight, which decreases that loading dose to a great extent, so toxicity can be avoided. Sometimes with that loading dose, you see a lot of toxicity too. So just wanted to bring that point up. And thank you. That's a great discussion.
Vidya, in your answer, you were saying about loading dose and things like that. We physicians, now we are very much interested time in target. We give blood pressure tablet all the 24 hours, same level of the level should be there to reduce the blood pressure. Otherwise, morning the pressure will be reduced, evening it will go up. Same way, the insulin, time in target. All the time, the level of should be there, then only the blood sugar will be reduced. So we talk about time in target in diabetes, time in target in hypertension, Same way, the antibiotic level, what you give in the morning, may come down in the evening or late off. Then the attack to the microbes may not be as effective as the in the morning. So that's why the time concept, the concentration concept is now becoming more vigorous. In the sepsis. What's
Yeah,
Suresh?
and sorry. I just want to mention that role of pharmacists. We use pharmacists a lot for stewardship as well as concentration. Now all the TDMs, the therapeutic drug monitoring, all that is actually taken over by pharmacists. So we have them help out with that process. And it really frees up a lot of our time. They're doing the med reconciliation. They're helping out with the drug monitoring, and they have a better understanding. They do it mathematically with plugging in formula and all that. So I think it's definitely a better thing for the patients to have a multidisciplinary team. Even for rounds, I'm sure that's already happening in CMC and other places. So having a multidisciplinary team and the pharmacist being important in this team, they should definitely be included because they have a lot of value to add. And the more we know about the drugs, where this is concentrating, is it in the tissues? So it's very important to use the right antibiotic. It's such a science, to make sure that the concentration is optimal. It's not, some antibiotics don't even stay in the blood that long. So, and bacteriostatic, bactericidal, all these need to be taken into account. So pharmacy is very important in these teams.
Thank you, Vidya. Sivakumar, your practical approach, Sivakumar, because you are dealing gram-negative septicemia and then shock and then ICU. So what is your practical points for us?
Sorry, sir, which aspect of it you want to know on the management aspect or diagnosis or?
No, in the whole overall approach and then management and practically, what one should, get from your experience.
Yeah, I think I mentioned earlier as well, sir. I think cultures are important and probably choosing the right drug is very important. So to choose the right drug, I think as we discussed earlier, you should have a local antibiogram. Unless you have this local antibiogram, I think you will not be able to make right choices. So in your hospital, at least you should have a data. So what is the common organism for UTI? What is the common organism for pneumonia? What is the common organism for bloodstream infection? And
in Coimbatore, do you do this quick, what Suresh was mentioning, the molecular culture?
Rapid identification test not widely used, sir. As of now, I think in most of the places in Coimbatore, they don't use this rapid identification, PCR-based rapid identification test. So what I was trying to say is every hospital should have a local antibiogram, and that should be circulated to all the clinicians periodically so that they know what is the organism they are coming across based on the site for UTI, bloodstream, and VAP, and what is the right antibiotic for different sites. So this information should be there with the clinician so that whenever they have the infection, so they may be able to make appropriate choices. So this is having an antibiogram at each institution level is very, very important so that whenever they have an infection, they will be able to make appropriate choices. So, good.
Okay. Yeah, that's good. Vidya, I'm asking a basic question. We are always talking gram-negative septicemia. Do you get gram-positive septicemia?
So gram-positives here, pneumococcal disease claims lives. In fact, from our experience here, gram-negative septicemia, if they're treated with the appropriate antibiotics, they turn around so quickly. Gram-positive, however, enterococcal disease, Staph aureus, pneumococcal disease, they take a long time. Staph aureus, enterococcus, they are typical bugs for endocarditis as well. So, that can become problematic as well. So any of those can cause sepsis, gram-positives or gram-negatives.
Okay. You already answered that question in the chat box, but anyway, for everybody's sake, what is the role of monitoring PCT levels in gram-negative sepsis? Dr. Nilakshi H. Samis. role of monitoring PCT levels? Any one of you?
I think probably I can answer that. My colleagues can add to it if there's any. See, procalcitonin earlier, I think we were using it more for the diagnosis of sepsis. I think now the data is very clear that probably it shouldn't be used for diagnosis of sepsis, particularly to differentiate an infection. So procalcitonin should not be used for diagnosis of sepsis. If at all procalcitonin should be used, it should be used for deciding your duration of therapy, or it should be used for designing your de-escalation. So earlier we used to use procalcitonin mainly to make a diagnosis of sepsis. Probably it shouldn't be used that way. It is predominantly used nowadays to de-escalate and to decide the duration of therapy based on the percentage of fall in procalcitonin.
Subramani, would you like to add any other point about procalcitonin?
I think that is one of the commonly misused investigation. People tend to use Procal for diagnosing. As Sivakumar rightly said, we can use it, when to decide when to stop the antibiotic. I tend to use less and less of it. Go by other clinical signs and symptoms. If you allow me, I'll just share 3-4 slides from our liver transplant, which we currently have in our ICU, and how difficult it is to this man. So this is can I share my screen?
Yeah, please go ahead. I will enable you to share.
This is, can you, I'm not going into the presentation mode. Is it visible on a presentation mode?
Yeah.
So this is a 58-year-old man who had a sarcoidosis, portal hypertension, liver failure. So this is on admission after a liver transplant, and he has been kind of hypothermic throughout. Last 4-5 days he's been hypothermic. He also had, we go to the next slide, you can see his
Subramani, sorry, your loading dose is good, but as you go, the dose is reduced. So wise dose, I'm telling you.
Okay,
so
sorry.
have the same loading dose always, please.
Are you able to hear me now?
Yes, please.
So
Don't de-escalate. Don't de-escalate, please.
So if you look at his white cell count, from 28, we see it's been kind of low. It's always his white cell count of late has been, because of the hypersplenism, it has been in the high thousands or low thousand, in the high thousands, 1,600, 1,700, like that. But then post-operatively, you see he's more and more leukopenic. And if you see his differential count, again, that the leukopenia, and you can see his absolute neutrophil count has been actually very low. And most importantly, if you remember last time I said there are a lot of which include the NRBCs, nucleated red blood cells, and you can see this is actually going up. And finally, if you go back, he has actually today morning he had a spike of fever. He did send some blood cultures. He had a spike of fever. Somebody had a liver transplant, who was on steroids for immunosuppression, and he did not manifest classical features. He was actually hypothermic, low white cell count, etc. And then suddenly he's done that. And then, not surprisingly, we found some. So this may be difficult to diagnose. There may be in such species who are immunocompromised because of the treatment. So other than that, the quick diagnosis and antibiotic stewardship is what will help in.
Okay. Thank you, Subramaniam. Suresh, you wanted to say something. In the meantime, you would have called the phone.
No.
Yeah.
Couple of things, sir. One, regarding the procalcitonin, Dr. Shivakumar rightly pointed out. For suspecting sepsis, it is not going to help out. Dr. Vidya clearly answered, for prognosticate, yes, it might help out, particularly serial monitoring of procalcitonin. But we usually use procalcitonin to stop the antibiotic. When 2 consecutive procalcitonin is normal, And our clinical suspicion is also sepsis is unlikely. We can stop the antibiotic comfortably. One. And regarding some of the questions, people are asking how to identify gram-negative sepsis. There is no difference between gram-negative and gram-positive sepsis. Sepsis is sepsis only. We need to think about the temperature. We need to think about the vital parameters and everything. Depending upon the source, where the sepsis is originating. That's why the simple thumb rule, what we say, any infection that is happening above the diaphragm, think about gram-positive. For example, meningitis, pneumonia, think about gram-positive. Anything that is happening below diaphragm, think about gram-negative. For example, intra-abdominal sepsis, urinary tract infections. Yes, enterococci is a gram-positive that can rarely cause an UTI, but mostly any infections above the diaphragm, 90% put your money on gram-positive. Anything that is below on the diaphragm, think about gram-negative. But in Indian scenario, for example, patient hospitalized with the ventilator associated, think about gram-negative, because compared to MRSA causing pneumonia in my ICU, gram-negative like Acinetobacter or Klebsiella is going to cause pneumonia. So the thumb rule for community sepsis, anything above the diaphragm, gram-positive, anything below the diaphragm, gram-negative. But in a hospital setting and Indian scenario, this rule cannot be applied. So these are the simple things we can tell. There is no signs of gram-negative sepsis and gram-positive sepsis.
Thank you, Suresh. Vidya, I think your point of bringing a pharmacist is very good, because now we have to, refresh our knowledge. What are the bactericidal, what is bacteriostatic, and what are the drugs for gram-positive, gram-negative, all that, we must revise. So we must have a separate talk on, the antibiotics and in, divisions, because now Suresh is adding concentration, time prolonged. So many things we have to discuss on drugs alone. So I think it's a good idea that you said you are a PG with pharmacy specialist who can present very nicely about this. I think we'll utilize him next week. Yeah. Okay. Any other point you would like to add, Vidya?
I wanted to, while we're talking about this community-acquired and hospital-acquired infections, that line is getting very blurred. I'm sorry, I was kicked out of the session, so I don't know if you already covered that, Dr. Suresh Kumar. My apologies, but that line is really blurry now. Community, you find a lot of these, what we typically consider hospital infections or nosocomial infections, particularly with staph aureus. We used to really have that distinction about community-acquired MRSA and hospital-acquired MRSA, where the community-acquired was still susceptible to some oral antibiotics. And that's more so for treatment, general treatment of skin and soft tissue, etc., those classifications. But now, you should take into account the risk factors, especially if somebody is coming in and out of the hospital a lot. They do tend to have more multi-drug resistant infections, but that line is really getting blurred in terms of community acquired and hospital acquired. So broad spectrum, you'll never be faulted for starting somebody on broad spectrum antibiotics. Time is of essence here. So you really need to have protocols, bundles in place. In fact, we have that as part of the admitting orders. It's like a checkbox. Anybody can do that.
Sorry. You were talking about bundles. Tell me bundles. Even yesterday you were talking about bundles. Tell me what is bundle.
Yeah. So they're just these standing orders that you have. ABC of sepsis. Make sure this part is done for the airway protection. Make sure that this is done for fluids. Make sure antibiotics are started on time. What antibiotics? They already have choices of what antibiotics to start, broad spectrum antibiotics. So, a nurse practitioner or our students, they just check those boxes to make sure that that's done. Cultures, based on what you think it is, a patient presenting with altered mental status. That's one other thing I wanted to say. Altered mental status does not always mean that there's a neurologic problem. Actually, altered mental status is one of the identifying signs for sepsis. Even on the floors, somebody's talking to you regularly, the next day they're a little altered. Sepsis should be on the differential diagnosis for patients who are having some kind of changes in their mentation there. So, based on that, you choose your antibiotics and check those boxes, and cultures should be taken, and that really becomes easier then for identifying the pathology and then management of these patients.
In fact, altered mental status and then something similar to it, is an early sign for, somebody is going to develop meningitis or encephalitis. We have diagnosed so many people when they are normal and then suddenly talk irrelevantly, then we know that, something wrong. And then we refer them, to high fever and eye infection. So last time Suresh also mentioned about altered mental, thing. I think that's a good point for the clinicians to know that that's also a part of, sepsis management. And
Yeah.
it is not
And sorry, need not always be meningitis or encephalitis. Even with pneumonia or a urinary tract infection, they can present with altered mental status. A lot of people of advanced age, that's in fact one of the first signs that they come in with. And unnecessarily, a lot of times lumbar punctures are being conducted on these patients. You give them antibiotics, within 24 hours they turn around. So that's important to remember.
Yeah, usually in any high fever, people start blabbering, saying something which is irrelevant. So this we see commonly also, especially in children. When they high fever, they tend to talk like that. It need not be meningitis, need not be encephalitis. Okay. Subramaniam, you are sleeping. Please come back and then tell me what some good points.
I'm not sleeping, sir.
No, just joking. I'm just pulling your yeah.
So some of the things what I've seen is people confuse between virulence and resistance. Some bacteria can be virulent, and giving antibiotic is not going to stop the progression of the inflammatory response the bacteria has set. And we need to support the organs till they start recovering. So people confuse between the virulence and the resistance, and they keep on escalating antibiotics and working in a center with a lot of bone marrow transplant going on. We see that hematologists will change antibiotic every 2 hours. So that needs to be clarified, and the degree of organ function. We have various scores, and if the organ function is deteriorating, and appropriate support at the appropriate time is important. So that's very much. And in this gram-positive organisms, we find, as Dr. Vidya said, the mortality is much higher than what we see with gram-negative bugs, especially when they go into the shock syndrome. It's very, very difficult to pull them out. We add clindamycin as part of the regime for the gram-positive shock syndrome. And we have tried sometimes even IVIG unsuccessfully. It becomes very expensive, and we seem to be giving it as a desperate effort. I don't know what Dr. Vidya's experience is with IVIG. I've tried on a few patients, which was futile actually, and that is one of the treatment they've suggested. But the gram-positive infections, though not very common, are very, very troublesome, in my opinion.
Thank you, Subramaniam, for bringing one good point. There is a difference between virulence and resistance. So you should not mistake the virulence as resistance and change the antibiotic every 2 hours. That's a very good point you have brought up. And number two, gram-positive, though it is rare, it can be mortal. Compared to gram-negative, it may be more dangerous. That's what you are saying now, Subramaniam?
Yes, sir. Yes.
Yeah. Vidya, do you agree about that? Gram-positive is more...
Absolutely. Yeah. Gram-negative sepsis patients, we can antibiotics are given in a timely fashion, and they're stabilized. They turn around much faster than the gram-positive organisms causing these syndromes. I just wanted to add, Dr. Subramanian, great point for clindamycin. Clindamycin has this antitoxin effect. A lot of the skin and soft tissue infections causing sepsis, necrotizing fasciitis particularly, this can be very, very useful. More than the antibiotic, in fact, clindamycin or the antitoxin effect of these some antibiotics. So linezolid, one of those antibiotics, has this. Any of the tetracyclines, anything that actually acts against the ribosome can potentially do this. But clindamycin, there's a lot of data on eagle effect, where it tends to act even in the lag and log phase, both of the bacteria. So it's very useful in binding the toxin that the staph and strep, especially with the toxic shock syndromes, which progress very fast. It's very, very helpful in management of these these conditions. IVIG we have used, actually we still use in toxic shock. The literature there is divided. It's plus minus if you review that. Personally, we see some good effects with IVIG when given at the right time. If they don't respond,
Vidya, please expand IVIG.
So intravenous immunoglobulins. So when you're giving that, you can give specific immunoglobulins for viruses. Certain viruses you have specific immunoglobulins for. So it's like passive immunity that you're giving. But again, these also have that toxin binding and reduction, the effect in reduction in the toxins from some of these bacteria, gram-positives particularly, which in their pathogenesis, toxin production is one of their the ways in which they act. These
so for every bacteria, and you have IVIG, like just like you have viral.
No. For viruses, it's specific. For bacteria, it is intravenous immunoglobulins. So you just give this, passive immunity for the patient, and they're able to respond pretty well.
So there is no specific IVIG for bacteria. It's maybe for only virus.
Yes.
Okay. Do you use metronidazole also nowadays? Metronidazole.
Yes. So for any infections where you want to cover, it's very important. When our trainees come to infectious diseases, I typically have them go through the exercise of making 3 charts. Every antibiotic, every antibiotic that covers MRSA. So antibiotics with activity against MRSA, antibiotics with activity against Pseudomonas, and then antibiotics with activity against anaerobes. It's very important. So some of the antibiotics have anaerobic activity already. But again, even that, an antibiogram will help you identify which one covers it better. So metronidazole has 98% to 99% efficacy against anaerobes. So that's like a default drug. A lot of the ID doctors used to teach earlier saying above the diaphragm, so gram-positive anaerobes, clindamycin is better. Below the diaphragm, metronidazole is better. Not really like that. Clindamycin does not have that good of an anaerobic coverage for the gram-negative anaerobes. So metronidazole is good. It acts everywhere. So above diaphragm, below diaphragm, metronidazole is good with 98 to 99% efficacy against anaerobes. So if you're using a 3rd generation cephalosporin, 4th generation cephalosporin, they do not have anaerobic activity. So if you're using that for presumptive coverage, then metronidazole actually becomes part of that broad spectrum coverage for antibiotics.
I think, Suresh, from your best of ID, you must bring out a chart. What antibiotic is better for diabetic foot? What antibiotic is better for skin infection? What antibiotic is good for urinary? Like that, bring out a best of ID so that metronidazole also can be included, and then it will give a rough idea as how we should go about it. Treating, even if you don't have a culture, waiting for culture in a secondary care, these things will be very helpful. I think we'll wind up. Before we wind up, we'll go one by one. Sivakumar, your one message about the gram-negative septicemia.
Thanks, sir. Just a comment about what Dr. Vidya was mentioning, sir. I think metronidazole is another drug which is frequently abused in our setup, because whenever they use a piptazo or a carbapenem, most of the time they have a good anaerobic activity. You don't have to add an additional agent like metronidazole for anaerobic cover. So a lot of these post-operative patients or other surgical patients, they do have carbapenem or they do have a piptazo and they have a additional metronidazole. So both piptazo and carbapenem, they have good anaerobic cover, and you don't have to add a separate agent for anaerobic cover whenever the patients are on these agents. That is one.
Yeah, Sivakumar, at the end of the meeting only you are making it very lively. Vidya, do you agree what he says, metronidazole not necessary? Do you agree?
Absolutely, 100%.
Oh, come on, say you are, agreed. I thought you will.
No, so she said clearly for ceftriaxone and ceftazidime, these type of drugs, 3rd generation cephalosporins don't have anaerobic cover. But what we are using in our ICU is not ceftriaxone. We are using piptazo, meropenem, digicycline. These drugs we are using it. All contains anaerobic cover.
Thank you. Sivakumar, your message apart from metronidazole.
I think just to conclude, sir, I think the sepsis, I think there are a lot of discussion in the chat box. How do you make a diagnosis? I think the most important is suspicion. As you all mentioned earlier, I think an elderly gentleman with diabetes with urosepsis can just come with confusion to your emergency department. Or somebody in ICU in the third week, they may just be hypothermic. That may be an early indicator for a severe sepsis. So suspicion is very, very important in diagnosis of early sepsis. That's first thing. Second thing, before you start an antibiotic, do appropriate cultures. Use antimicrobial judiciously. The last but most important thing is, I think the infection control is most important. I think wherever you are, I think to prevent, we are in an era of MDR infections. I think to prevent these MDR infections, I think we should practice infection control in the most effective manner. That's all, sir.
Thank you, Sukumar. Subramani, your comment, final comment.
So appropriate use of antibiotic is what I will back for. I enter the ICU thinking what antibiotic I'm going to stop today.
Okay, very good.
That should be that is my approach, and that should be everybody's approach.
Very good, very good. Nice, Sumani. Vidya?
Yeah, I will say that, as we progress, knowing more and more about less and less, we have people who are super specialists and super specialists. So we know more and more about less and less. I really think we should look at management of our complicated patients as a team approach. So what others can do better than us, we should involve them in the care of our patients. So having microbiologists, having pharmacists, having nursing care, all of them be part of the team rounds is a good opportunity to give our best care to the patients that are very complicated and have high mortality if they're not treated in an appropriate way. So I would just say that team-based approaches for these complicated patients is something that I would highly advocate for, and we are moving towards that. Their guidelines, I think we're going to talk about that next time. ICU and IDSA did not quite agree in some of those things with surviving sepsis guidelines last time. So this time, I think 2021, there's a little bit more agreement. But there are guidelines, different sets of guidelines. Do not get warped up in these guidelines. A patient comes before guidelines. Guidelines are always black and white, and patients are shades of gray. So definitely use that knowledge, but use it tailored to the patient. It has to be very specific to the patient. So shotgun approach, start broad, start what you need to, and then tailor it very specifically to what the patient needs. That's where your teams can be very useful. And lastly, I don't want to undermine the importance of source control. We talked a lot about using the right antibiotic. Dr. Shivakumar mentioned that multiple times. It's very, very important to identify the source. And if surgery is necessary to control that source, there's an abscess, big abscess that's sitting there, you can change your antibiotics as much as you want, but it's not going to help the patient or get better if that source is not addressed. So those are my three takeaways in addition to what has already been discussed.
Thank you very much, Vidya. Now, Suresh, your final.
One episode of fever or one WBC count elevation is not antibiotic requirement in ICU. So assess the patients in full. So most of the time, what happened, one episode of fever 9900, immediately the antibiotic was changed. And the WBC count gone up from 9,000 to 12,000 or 11,000, immediately they want to change the antibiotics. Pan cultures. The second thing is pan cultures. Pan culture, we used to say people doesn't have mind, because when we examine the patients, where is the source of sepsis? Accordingly, we need to send appropriate cultures. That's the best answer, not the pan cultures. Sending blood, urine, sputum. That's not the answer. Usually send where is the source of infections. Send appropriate cultures before starting antibiotic or before changing antibiotics. That is more important. And we are living in 2022 era. If you send cultures, call the lab or check the lab whether the growth happened next day or not. Don't wait for 5 to 7 days. The time is gone. We are using automatic system. Most of the places, whether secondary or tertiary or even primary level, people are using automatic system. We need to call the lab or go to the lab personally, check what happened to my blood culture growth, what happened to my sample sent yesterday, whether it's growing or not. That is most important thing. And rightly pointed by other speakers, antibiotic stewardship as well as infection control. This is a gold standard because we need to prevent. Treatment is the second part. Prevention is most important thing.
Thank you, Suresh. That's what Vidya said. It's a team effort, especially you will allow to involve microbiologists and also your sweeper in the hospital, in ICU. More important, when Sivakumar doesn't get the sweeper on time, he gets nervous. The most important, the floor cleaning, the surroundings cleaning, everything is important, infection control. I think we had a very good discussion. Next time, there's a small change. Instead of Suresh Kumar, Dr. Subramani will be, leading the attack. He'll be the opening batsman, and followed by the number 1 down will be Suresh, and then 2 down will be Vidya, and 3 down will be Sivakumar. So next time, that is 4th Friday, we are going to have a guidelines, and we can also cover all the other points which we have not covered in sepsis. So overall, we'll cover all the points. And Subramani, you will speak on the guidelines for 20 minutes, and then followed by the discussion. Is it okay, Subramaniam?
Yes, sir, yes. So it will be general guidelines to how we, like your surviving sepsis campaign, the guidelines. Because antibiotics, I think we have discussed now, and the rest of the management.
Yeah, I think the flow of events is like this. Any suggestion, Suresh? Because all of you there, we can get the flow of event properly, so that Subramaniam will, prepare accordingly and then give the presentation.
Yes, sir. Because surviving sepsis guidelines we not touched about. We are talking about the antibiotics, diagnosis, and stewardship and everything. So we need to talk about the surviving sepsis. Apart from antibiotics, apart from the infection control, a lot more. Dr. Shivakumar and Dr. Subramaniam knows better than what we are doing with it. So we need to see about the fluids. We need about management of sepsis as a whole. So they need to guide the last part of session there.
Okay. So Subramaniam, please, prepare that way, and then you present. And after that, we'll have a discussion like this.
Sure.
Is it okay?
Yes,
perfect. Sorry to ask you the last minute.
No,
because you are doing day in and day out the same thing.
It's bread and butter for me.
It is not a big thing for you, because actually Suresh was supposed to do, but Suresh said you will be a better person because you are dealing more every day. Is it okay, Subramaniam?
Yes, sir, perfectly all right.
Yeah, and then it will be supported by all our people, and Sivakumar also is there.
Sure.
Okay. So thank you very much. And Vidya, Subramaniam is a very nice person. He also belongs to our area, my area. So he's heading the department of the ICU in CMC Vellore. Have you been to CMC Vellore, Vidya, earlier? Yeah.
No, but so of course, it's a national leader. So everybody knows about CMC.
So we will organize one live program where we will invite you also to come to CMC. So all of us will go to CMC and then do some program in CMC. Excellent. Thank you very much. And please don't forget, on 4th, same time, 9 p.m., we are going to be there. Very important and interesting topic. All these webinars are in the website, Whole Medical Academy, and then Doxyflex website. So somebody who's missed it, they can always download in Doxyflexes and see. Doxyflexes, Vidya, is one of the platform where they have international connections and a lot of data they have, and a lot of clients are there for them. So after this, we are going to plan some more webinars on infections, which we'll come back to you and ask you. Thank you, Vidya. And if possible, ask Raj to be there if possible on Friday if he's not on duty. Thank you for coming and then enlightening us, and then give me all the highlights of the program by slides so that I'll put it in our WhatsApp group. You have said you got a basic, that pharma people have got. I mean, the pharmacy person has got some basic slides. You pass it on, and Suresh also every day is giving the best of CID. So we'll put all that, and then we'll put it in the WhatsApp and also the website. Okay. So thank you, Sivakumar. Thank you, Subramani.
Thank you, sir.
Thank you, Vidya, Dr. Suresh Kumar, and Dr. Sitil. Thank you. Okay, we'll meet on Friday. Take care. Stay safe. Good night. Good night. Good night. Sorry. Good morning, Vidya. Enjoy your work today because you have to go back to work now. Yeah, please go ahead. Thank you. Thank you. Right.